All right, good afternoon, everyone. My name is Ron Emerson, and I'm the Global Healthcare Lead at Zoom, and or good evening, depending on where you're at around the world. First of all, I just want to thank everyone for taking time out of your busy schedules to join us today for a very important topic, which is healthcare gone hybrid, different care delivery models, and I'm really honored to be hosting this and moderating such a distinguished panel. As we look at how virtual healthcare can impact us now, as we're still in the midst of something the world hasn't seen in many, many years, and of course the impact it can have in the future. First of all, I just want to introduce our panel, and we have Safaa ElHassan, who's the chair of Digital Health Standards and Guidelines of the National Committee of Saudi Health Council of Saudi Arabia. So welcome, Safaa, and thank you for joining us. We have Joe Hawayek, who is the Telehealth Program Lead for Aetna Insurance, and he is out of Dubai. Thank you very much, Joe, for joining us today. Dr. Osama ElHassan, who is a ISfTeH board member, and he's the co-founder and vice president of the Emirates Health Informatics Society, health informatics specialist, and the co-founder and coordinator of GCC Taskforce on Workforce Development in Digital Healthcare. So thank you, doctor, for being here with us today. And we also have Dr. Penny Trainer, who is a pediatric clinical neuropsychologist and has been heavily involved in the use of telehealth, providing clinical services, and also some other interesting things we'll be able to hear from her today, who's a clinical psychologist, and she is out of the United Kingdom. So thank you, Dr. Trainer, for joining us today as well. Before we start, I just wanted to sort of give an overview of a 2 to 3 minute overview from a global perspective. So first of all, as I said, we're all in the midst of still dealing with certain aspects of the pandemic, depending on where you're at around the world. We're all in different phases of restrictions and access and what people can do and how they can move freely. And of course, that impacts specifically how we access medical care. The first question is, when we look at virtual delivery models, I think we all know that, of course, COVID has provided this digital acceleration of how we all use technology. And it'll be really interesting as we have thought leaders on here today to look at kind of where we're at now, and then some models, and then what does the future look like, as we move and as we deal with, as maybe COVID won't go away, but as we get to the point where it becomes a norm and we live with it, and what does digital health look like? But I think the first question we all ask is, do patients like it? Zoom actually did a study. We actually had someone do a study called Qualtrics, and looked at 10 different nations around the world. And we actually looked at people who had done a video visit, right? Who had actually done a video visit with a clinician within the last 6 months. And what we found is that that 64% of them said that they would prefer a hybrid model of healthcare, that they wanted video as part of their interaction. 32% said no, they just wanted in person. And then there was the remaining, which I think is about 4%, that just wanted to actually use video only, right? But just to set the foundation, of course, telehealth can mean a lot of different things in telemedicine, and this was brought up by Osama yesterday when we had our pre-meeting, which is true. It's the transfer of electronic medical data. That can mean remote patient monitoring with biometric devices. That could mean it could mean store and forward technology, where you take a snapshot of a lesion and send it to the other side. It can mean a live video interaction. It can mean a lot of different things. So just keep that in the context as we go through our discussion today. So I'm going to go ahead and start out. And Safaa, I'm going to start with you. And if you could just kind of provide just an overview of course, yourself, your background, and what your organization does in regards to virtual care.
Hi, Ron. Good evening, everyone. I'm honored to be here. So my name is Safaa Majzoub. I'm from Ministry of Health, presenting Directorate in Strategic Planning and Clinical Governance at the moment. This is where I come here every day to the medical virtual medical center in Riyadh, Kingdom of Saudi Arabia. So yet actually we're expanding this national hub. We're reaching out to 130 plus hospitals We have thousands of physicians who already connected to this platform. The services are actually growing and expanding. And I'm really excited to talk more about this experience as we move forward. Thank you, Ron.
Wonderful. No, thank you very much. Great intro. Dr. Trainer.
Thanks, Ron. My name's Dr. Penny Trainer. I am a clinical psychologist and a pediatric neuropsychologist. So my specialist area is the delivering pediatric brain injury rehabilitation. So I have a service based in Manchester that I've been running for 13 years. We see children all over the United Kingdom. To put it in context, in the UK, there are less than 40 pediatric clinical neuropsychologists covering the entire country. So we're very busy and spend a lot of our, prior to the pandemic, spent a lot of time on the roads, visiting patients, delivering interventions in the homes, in the community, as well as people having to transport themselves quite far to come and see us. So actually prior to the pandemic, we were already well on this track of looking at this model of hybrid delivery. We had already, as well as being a neuropsychologist, I'm also a health tech entrepreneur. So I've developed some rehabilitation software to aid us in being able to do multidisciplinary teams remotely, monitor patients remotely, set goals remotely, track outcomes. We were doing that prior to the pandemic because this was already an area of difficulty for us. But as you say, what's happened, Ron, is that we've had this acceleration. We as neuropsychologists could not stop delivering healthcare because we have patients who've got acquired brain injury who have a very limited window for which they can receive treatment to get the best outcomes. So we had to find a way to deliver. So I think, going back to that question of telehealth, I think I've used it in both ways. I've used it in a clinical way to adapt the interventions I've delivered to patients, which I'll talk about later. But I've also used it in an administrative way to improve what we can do as clinicians to speed up our workflow, so it feeds us up to do the good stuff, the clinical work. So yeah.
Oh, wonderful. Look forward to hearing more about your personal experiences, especially on the clinical side. That's great. So Osama.
Hello, yes. So my name is Osama ElHassan. I'm a software engineer by training. I work for Dubai Health Authority. Dubai Health Authority is a government service, healthcare service organization for the covering Emirates of Dubai. And we are also the regulator for the booming private sector, which includes many hospitals and healthcare facilities. So within my role in DHA fits with the regulatory sector in a department called Health Informatics and Smart Health. Our role is to create and execute a sustainable digital health strategy for the Emirates. Part of our digital strategy, we regulate also virtual care. And we know that this is a very tough job, as we need to maintain not only just the strategy, but we need to lead the change management that includes cultural processes and architectural change, which is within the digital healthcare arena. Thank you.
Wonderful. Thank you very much. Looking forward to digging more into that. And Joe, please.
Hello, good morning, good afternoon, good evening, everybody. Thank you, Ron of Zoom. Also, thank you to the International Society for Telemedicine and eHealth. My name is Joe Hawayek. I look after virtual health at Aetna, the medical insurance company, the global international medical insurance company. I'm based out of Dubai. I've built my career over the last 20 years, coming from software engineering, data analytics, and most passionately about the delivery of healthcare services using tele channels, digital channels, computers, devices, anything like that. And what we do at Aetna is really provide a primary care healthcare service to all our insured members. And of course, this means their very first point of contact with the healthcare system, especially the types of customers and members we have. They're typically expatriate from their home countries. So they're typically on secondments, on other jobs. They've moved countries. They're likely to be in a country they don't speak the language. They're very likely to not understand the healthcare system. So we give them that convenience of a safe, patient-safe type of healthcare service that can be the first point of contact. It happens over video or phone. We're not too specific. We can give that choice to the customer. But what's important is that they speak to us first and foremost early on in the process. The earlier they can let us know, and our doctors are able to diagnose early conditions. It's so much helpful for them and their health, but also for the bottom line of medical claims. And that's where we come at it, that we can control medical claims escalating so much better when we can treat earlier.
That's wonderful. Thank you. Thank you, Joe, and thank you to the rest of the panelists for the great introductions. We have a lot of different type of experience on here, so this is exciting. So, Joe, I'm just gonna, if you don't mind, I'll just continue on. We can continue on, and I guess one of the questions, Joe, as an insurer, you know, we've in the world that you live in, of course, we all realize that COVID, it's accelerated virtual care delivery models, right? And as an insurer and provider, what do you think from your perspective, we've run this experiment over the last, you know, how many months, right? And just to give an example and kind of the changes we've seen, and I'll be a little US centric here because that's where I'm located, is we know that prior to COVID, people that could receive care, as you're an insurer, Joe, people that could receive care and their insurance paid for it virtually, let's say like on a mobile device, less than 3% of people actually use that opportunity to do that. And self-insured employers, also in the US, we showed that less than 3%. But during COVID, we were pushed in the use out of necessity to decrease exposure to the virus, right? So in the bigger centers of excellence, it could be 75 to 90% of all outpatient visits were virtual. And McKinsey did a report that showed overall across all segments about 50%. Now it's about 12 to 17% as we're kind of coming out, the outpatient visits are done virtually. So kind of putting it in perspective, we've learned a lot. We were pushed into this experiment. Out of that experiment, Joe, what's the largest lesson learned you think that you found in your organization and the population that you serve, your members?
So we had been already delivering telehealth before the pandemic in a limited way, just like you described there. There were segments of our members that were using it. Some of them weren't even eligible, some number of reasons. So we've been operating a telehealth center out of Dubai, licensed from 2018, one of the first 3 or 4 or 5 telehealth companies in Dubai. So we'd already been doing it, and we had capacity. So we felt there weren't enough people using it. We were doing a lot of marketing, engagement, convincing, almost begging people to use it. Try it once, we'd say, it's a real thing, it's a real doctor, and all of these kind of discussions that you might be familiar with. With the pandemic, they were forced to, like you said there, Ron. They were forced due to lockdown, due to not being able to travel to see physically a doctor. A number of them, of course, were not needing to be a COVID-related issue, not at all. These were during the times of a COVID lockdown, but they had all the other types of medical conditions that they needed access to a doctor. And so we saw a very strong peak in the utilization, which was great for us in the beginning because we felt we were doing the right thing and giving back to our population that we serve. But then it remained so high during, you know, from the second quarter of 2020 and then going into the end of 2020, it was so high that we wondered if we were able to offer the right people the kind of service. So we were maxed out, but are the right really needing, the ones who need the most care, are they getting through? So we started putting in more of a mechanism to manage this demand. So in terms of triage, so there was a 2-level triage service. So we would identify through a briefer consult, usually with a nurse or a healthcare allied professional, somebody who can do initial triage to work out what is really the level of severity, the level of urgency, and these kind of things. Of course, if it was an emergency, they needed to go to the emergency room. But if it had an urgency that was higher or lower, we were able to book them in appropriately, duration of a consultation appropriately, and things like that. So we managed that demand that way when we found we were maxed out and we still wanted to address the higher needing patients. And then in 2021, this continued, although indeed the graph shows us that there was less utilization. People started going to the physically to see their doctors, but we continue to take on new members, and that always introduced more and more need, and so that continues. So if it was really one lesson, is when we're not so busy, we're happy to offer consults to anybody. But when we got really maxed out, we started having to be selective, in a good way, selective in offering our doctors' time to those who need it the most.
That's wonderful. Yeah, and we're seeing a lot of that in telehealth being used. Just the whole risk management, right, based on the risk and what people need. That's a good point. So, Dr. Trainer, you've been doing this. You've been looking at this and doing this pre-COVID. So, and you've been in the midst of it during COVID. So, what's your largest lesson learned?
Yeah, I think my biggest takeaway has been actually, how useful this is, but actually it is about that targeted approach. There are some things that are highly amenable to this virtual approach, particularly within neuro rehab. I don't think I can envision myself regularly ever attending multidisciplinary team meetings. I mean, I used to do between 500 and 1,000 miles a week sometimes, going off to meetings to be present. It's no longer necessary. And I think that there has been that change in people's buy-in. I think going back to what your comments earlier, I think people felt that initially, if you were given a virtual option, it was a lesser option, that somehow you were getting a lesser option than seeing me in person. But actually, people have realized, actually, for me personally and professionally, you get a far better service because meetings are easier to manage. I can exploit all the extra features. I don't have to carry lots of paperwork. We can share things readily as teams. So, and like with my software, it works perfectly because we can load it up and sit there and work on all the goal data together, look at the outcomes, look at the graphs together, sign it all off. There's no paper being exchanged. It's fantastic. We have, adapted some other things. So we, obviously we had to find a way to deliver virtual therapy. As healthcare providers, we were permitted to go out to see people in person during the lockdown period, but obviously we had to be selective in who we saw. So largely I saw people with quite significant communication impairments who at the time, now different story, but at the time they were struggling to access. So what we did, we looked at different kind of adaptations. So we'd be on Zoom calls, sharing screens with people. There's all sorts of games that you can play with young people in particular, but actually adults as well, that you can have a two-way conversation, a two-way interaction by using some of the remote access features. So that was really nice. Obviously, our biggest problem was testing, neuropsychological assessment, which has, frankly, been behind the times for some time in terms of remote administration. It is still not that we do have some remote administration, but it's actually you still at the moment need to be in the same room as the person. But what we did was we had eventually, when we realized we had to get resuming testing, because like I say, we couldn't leave these patients, we would be able to have a technician or an assistant psychologist in the room with the patient in full PPE, whilst I, the qualified clinician, was administering the tests virtually. So that was a really good workaround. It's not suitable for all purposes. I do lots of medico-legal work. I wouldn't be using it in that arena because there's too many threats to validity, but I'm talking about kids that really needed to keep going with their education. We needed to know what was happening with us, with them, so we were able to adapt. So yeah, multidisciplinary team meetings, I think, have probably been our biggest success. But I think, thinking about the comments people have said, young people in particular really like this way of seeing me, having psychology sessions. The sorts of feedback we get, like actually they're far more regular. We can have short sessions. So rather than waiting 2-3 weeks to get back on my list, we can see each other twice a week. Sometimes I was seeing some individuals for half an hour, shorter sessions that actually suit them much better, much easier to bring in family members. We could bring in schools. I mean, today is a great example. Just before speaking to you guys, I was doing a meeting with social services. Immediately afterwards, I've got another meeting elsewhere with a parent. I couldn't do that. So, it's totally changed the landscape. So I think all of that stuff is here to say, but I think we as clinicians actually need to have quite a role in saying, what is it working well for us for? Where do we need to focus our efforts and target our efforts? And just as Joe was saying, I still need to see people. There are people out there that still need to see me in person. How do we make sure we get those people funneled to us much more quickly? I think are some of the questions we have to ask. But honestly, I've treated some young people in the last year that I've never met in person. I do lots of treatment for tics and Tourette syndrome. I've seen people now all over the UK and I can treat them, see them, they're done, they're discharged. Something that was massively impacting their life can be sorted within, a couple of months. So, it's amazing really, but we do need to be focused, we need to be targeted, and we need to think about where it's best used. And as Joe said, there isn't unlimited capacity in any of these areas. So we just need to think what pots do things belong in and where is it best delivered? Yeah.
That's great. And kind of a parallel I think that a lot of us can relate to, as you said, people felt like they weren't getting a sufficient service or it wasn't good enough. And, that reminds me back to the day, remember when distant education, it depends at where you're at around the world, right? Remember when you would go to university and then when they started offering distant education, at least I did. I kind of saw it as like subpar in the beginning. I was like, oh, wait, if you're just doing this online, can I get my master's degree? And it's subpar. And, you know, again, there's a lot of different countries that are attending and a lot of representation here, but I don't think people in general look at it like that. I think a degree that's, you know, gotten virtually or from a distance is considered as, you know, in line and in par with if you were going into a classroom every day. So I think that's a nice parallel.
I love that. My assistant psychologist did an entire master's degree last year without once going on campus, you know, and I just thought that is the new world. And you're right, it's not a lesser option anymore. And I'm glad that is the case. I'm glad people believe they're getting good value for healthcare. It's just delivered in a different way, a way to suit them.
Yeah, it's just a disruption. So Osama, do you want to add on to that? What have you seen as the largest lesson learned that we learned through COVID?
Thank you very much. So I'm just to talk about our story in DHA. So we started a program in 2019 called Doctor for Every Citizen. It was a very ambitious program, by the way, but we decided to put it in phases. So we started with virtual primary care program, which was a very simple one. We have like 10, I can say 10 participants from our primary care team who's been receiving virtual calls from our patients. This was, I can say, started very slow mode. I remember in 2019, we were getting around maybe a couple of hundreds phone calls or virtual calls every week. When the pandemic started or initiated in Q1 2020, we started to see a huge surge in the number of calls. And I remember in 2020, we got around 83,000 virtual call. This was a huge surge in the numbers. And I remember that among them there were around 7,000 calls related to COVID. So you can imagine here that this was kind of a way to manage our patient during the lockdown time. And it was really supportive. However, I believe that by the end of 2020, now we came back to the normal, and most of the patients managed to see their doctors face to face. However, we see a huge demand coming, not only from DHA, but also from private sector, to come up with more, I can say, comprehensive offerings with regard to virtual care that allow patients to see their doctors in a way that is augmented with face-to-face. And this actually required some sort of new, I can say, new models of care. So this telehealth should not be a separate silo service. It should be interleaved by with workflows. And this is very, I can say, tough mission. And we are working on that.
That's wonderful. Thank you. And Safaa.
Sure. In the beginning, as we've all known about the existence of virtual healthcare models, they've been around for quite a long time ago, but they did not probably find enough attention, whether from health practitioners or from members of society. And this may be due to the lack of belief in the role of technology in the health sector. But after the emergency of Corona pandemic, the situation have changed, and virtual health basically became a necessary, and it becomes a necessity. It's no longer something you can just choose whether to have or not. But the provision of these services was limited to limited specialties, due to the lack of readiness to use those solutions in the most specialized services. However, after moving forward and advancing in the use of modern technology, it seemed to find greater interest and greater popularity among members of society. And through the development of our experience throughout this time, it's been realized that these modern technologies can be used on a larger scale to bridge basically the gaps in the health sector, and that it is the best way to support the health transformation process. And this what should be actually done in order to meet the needs and bridge the gaps, which will positively affect the health of citizens and residents. And this is what we actually we experienced ourselves throughout the pandemic time, and we're still working on. And basically, this is the I'm currently at the Virtual Medical Center. It's a national center here in Saudi Arabia, and this is actually was born recently. It's like right after pandemic, so it's just like 6-7 months old, and it's growing so fast. It's really great what we're experiencing, and I'm going to talk more about it in the probably upcoming question or discussion questions.
Oh, wonderful. No, that's a great overview, though. Thank you very much. So that was a great overview from a higher level from all of the panelists, and I know the attendees. We will be sending the recording of this out after the session, so others can view it as well. But let's dig a little bit deeper into actual use cases. Let's get a little more granular in our approach here. So starting out with you, Dr. Trainer, if that's okay, can you just give just kind of go a little bit deeper into the actual use cases of how you're actually using virtual care delivery models?
Yeah, so I was just, we sort of did a presentation on this as part of Zoomtopia, didn't we, Ron? Because like I said, this has been such a revelation, really. So just kind of going through those sort of bit by bit. I've got some slides if you want to have a look, but I'll sort of do my best to describe. So in terms of neuropsych testing, actually, I'd like to just refer to Safaa's point, really, that the issue there is also not only the practicalities or the restrictions imposed on us in terms of testing by the test companies, but also the technology itself has been a barrier. If there is a drop in any of the connectivity, if the recording doesn't happen properly, if there's any issues with the way that the client has to interface with you, it really will impact the validity of the findings. So actually, like you say, those advances in technology, I think, has really helped us in terms of usability and acceptability. That's a really good point. So yeah, neuropsych testing is an area where we have continued to, where possible, to resume this hybrid model. But actually, I think within the next year or so, you're going to see the major test companies coming through now with totally virtual options, because I think it is the way forward. Where we tend to be using it more is in therapeutic interactions. So within neuropsychology, we've got lots of kind of different roles. I guess typically we'd be meeting with an individual and going through their areas of difficulty, perhaps delivering an intervention. So what we've been doing over Zoom, I've got a few different kind of computerized training modules and cognitive rehabilitation programs. So we do those together in the session. It gives me a chance to give live feedback. So actually it works actually far better. It's actually less weird than me sort of looking over their shoulder on a computer. So that would be typically what we do now. And those are sessions that I will long continue on Zoom. The other area, like I say, is multidisciplinary team meetings. So, I think a lot of healthcare providers here will be familiar, certainly the insurance company will be familiar with the cost of these. It's enormous. I work with young people that have catastrophic injuries. So they typically will have the entire gambit of multidisciplinary team working with them: occupational therapists, speech and language therapists, physios, psychiatry, neuropsychiatry, everyone's there, neuropsychology, education providers, social care providers. So now almost entirely those meetings would be done remotely, not only actually just to reduce the risks in terms of infection control, which was a primary concern, but actually we've realized there are huge benefits to the team in terms of them being able to collaborate, communicate much better in this manner. I really think it is the way forward. It massively reduces the cost to everyone. I think the insurance companies have probably been breathing a sigh of relief if they've watched all these virtual bills coming in, because actually it's a massive expense, but actually it comes at a cost to us clinicians, because when I'm driving to go to meetings, I can't be seeing patients. And, I have a waiting list already into 2023. The people need to be seen. So we need to be using these sort of methods to make us more efficient, and MDT meetings is a big hit. So yeah, that's probably where I use it the most. And like I say, treatment, because we can now treat people globally. So I have patients that I do see in other countries. It's much easier to be able to do that. It was almost, impossible to be able to do that previously. And all the kind of issues with regard to working across country, and a lot of those boundaries have been sort of overcome, really, because we've had to do this. So suddenly the insurance companies are telling us you can go and do it. So So typically, multidisciplinary teams are probably my biggest area, but actually most therapies will be delivered in part hybrid and face-to-face. In fact, often the only time we have a face-to-face session is at parent request, not necessarily at the young person's request, which I think tells us everything about where young people are at the moment. They are quite happy to log on, have a chat with me and log off and get on with whatever they were up to on Instagram or whatever. So yeah.
Oh, those are some great points. And it's really interesting. I've been doing. I used to run a telehealth network up in Maine, which is where I'm sitting now, which is north of Boston in the United States, and it's really interesting. I've been doing this for about 25 years, just nothing but telehealth. Like some of the other folks have been doing it for quite a while, and back in the day, as we say. I kind of looked at the industry and I was like, what are the three things that I'm always challenged on? Like, as I go to new doctors and clinicians and say, hey doc, and I'm sure, I can't remember who brought that up earlier. I don't know if it was Safaa or it was Osama, but someone brought it up, or maybe it was you, Joe, about bringing clinicians on, right? If clinicians were resistant to using it. And there were kind of three things and I'm like, wow, what do I get challenged at all the time when I ran the network? And then I got into the corporate side of it as, now I'm with Zoom, but I was like, the patients like it, they're who we're here to serve, right? We're here to serve. That's why we all got into healthcare. And when you look at satisfaction, we even in our network did a ton of surveys back in the day. And, satisfaction rates have always been, 90th percent, 88%, 90th percent or higher. The next question I think that we have to prove, and which is in this question, and Dr. Trainer, you cover some of it, is just clinical efficacy. How well can we provide care virtually compared to in person? And I think a lot of that, what we've understood is that it depends on the intent and proper processes for inclusion, exclusion, for when do we escalate, when are certain conditions not appropriate. And you mentioned that earlier, Dr. Trainer, you did a great job of articulating that, of how we can use it when it's right. And then I think the third thing that we all need to consider, which is unfortunately what everything seems to come down to in the end, I guess because we do need sustainability, is the financial end of it. How do we increase revenue? If you're a private organization, that's what they're looking at, while still providing quality care, right? And then how do we decrease cost? Public systems, of course, are increasing, just like every, which every system should be, is just equity, access to care, and so I've kind of looked at those 3 points. And I think on the clinical efficacy side, especially in your area, Dr. Trainer, for years, we've had a lot of comparative studies that have showed if a clinician sees if you saw me in person and made a diagnosis, and then another clinical psychologist, you walked out of the room, and then another clinical psychologist saw me over video, that basically the diagnosis is there's no variance, and as if you both saw me in person. But as we know, we're still working through some of those other specialty areas based on uses and use cases. So just a little to add a little more to that, but it's very interesting and it's an exciting area. So, okay, Osama, just some practical sort of how is your health system using technology and virtual care? A little more granular.
So actually, as I said, even after COVID now, we see still most of the stakeholders, clinicians and even facilities, are still interested in virtual care after COVID. Actually, because it's addressed rising demand, cost, clinical shortage, even consumer expectation, which is becoming very high after COVID. They want to have virtual care as part of the patient experience, as part of the digital front edge of the hospital or the healthcare system. This is becoming very important. And however, they still need to be nudged or to be compelled to build what we can call a new care models. Because actually the virtual care or the telehealth is still against what we call fee for service, which is still there in our region. So moving slowly to value-based care requires, I can say, clever utilization of virtual care. I think this is the key. Another thing which is a bit localized to our region, I believe that virtual care can be used as a tool to bridge some gaps in our healthcare system. So I can give you one example for that. So one of the huge gaps that we have in our healthcare system today is the leveraging the primary care. So here in our regions, normally if someone has a chest pain, to go directly to a chest physician or to a cardiologist and bypass the primary care. And because the primary care are not empowered enough for that. So I believe that virtual care can be very useful tool to close the gap of connected care between primary care and tertiary care, and develop some sort of more collaboration between them through doctor to doctor, even telehealth. I think this could be a great opportunity for us to utilize telehealth in the best way. Thank you.
Wonderful. Safaa, do you mind giving us some sort of more granular use cases that you see within the kingdom?
Sure. Virtual care delivery actually been delivered in different shapes, but I'm going to talk about an innovative design that invites collaboration among colleagues at the virtual medical center in Riyadh, for example, and remotely at a patient hospital location. Provider to provider model is currently serving patients remotely at nearly 130 hospitals across the kingdom. And this number of hospitals and primary centers connected to the central hub is actually growing. This national facility is dedicated entirely to telehealth outside its own walls. It provides well-trained consultants in rare specialties to support other care providers through different shapes of care delivery, such as, for example, referrals, a second opinion, teleconsultations, telemanagement, critical care, support and guidance. It's also worth mentioning that services are activated based on actual need and demand. So we do have like a group of experts, group of representatives from different sectors where they actually come and discuss based on statistics and data, demands and needs. And actually, we don't want to end up having like a hub for hobbyists just because it's cool to have digital health or telehealth service. No, it's actually targeting a different group of people, closing, bridging gaps. It actually meets needs and demands. So these models definitely help achieving better health outcomes, easier access to care, and we've seen it, clinical excellence, and knowledge transfer, because we really activated many of those, what we call probably outreach clinic or shared clinics across different regions where niche experts here, they're not only delivering the care, but rather transferring the knowledge to those providers and clinicians who practice in suburb area, probably need guidance and support throughout a full treatment plan. So this is a big part of it, of this virtual care delivery, is actually educational. And of course, also the cost aspect of it, like it's really cost reduction. We've seen it quite prominent.
You know, Safaa, I'm sorry. I love that model. And it just makes so much sense. You know, we don't just have a shortage of specialists and specific healthcare providers, but we also have a maldistribution, right? They're in the larger centers. But the model you just discussed, where you can have basically a specialist assist in a lot of cases and a general practitioner, and it can be on a consultative basis. So you can get that expertise where they're providing consultative basis, but the general practitioner still provides the direct care. So it really frees up the specialist to be able to see more patients and provide that. And then if the general practitioner needs assistance, they can go back to the specialist as a resource again. And that model is just so effective. So thank you for sharing that. Do you have anything else? I apologize. I think I might have cut you off.
No, you're very welcome. I do have a use case. I'll share it with you later after, probably like really a true story where I feel like I really want to share with the audience.
Okay, wonderful. Thank you very much. So Joe, just some granular use cases.
So this discussion is very much why we even came into being as a business within Aetna, the telehealth business called Virtual Health. So it's all to fill in that gap in the primary care, just like Dr. Osama said. Someone with a chest pain goes straight to a cardiologist because their insurance provider is able to cover it, but that's not necessarily the case that they're getting the best care, because it's likely that it's not even to do with their heart. It could be one of the examples we had actually a few of, that it turns out to be chest muscles on a number of occasions, or reflux, or what do you call it? So a number of these other medical conditions. So you have a situation where a person or a patient is self-diagnosing. And so that's why we've been very, very keen on it's not just about delivering digitally or delivering tele consults. It's about addressing that primary care need. through speaking to a primary care physician. This is your GP, this is your family doctor who's able to diagnose the breadth of healthcare issues, physical and to some extent mental healthcare, and that they're able then to channel them to the appropriate care, the right specialist, the correct subspecialist, and all of that. The tools or testing that we are able to deliver over telehealth, that of course is crucial. It is not the case that we're using very high-tech things. All we do, we send somebody to the home. So the consult is delivered over telehealth as a teleconsult. The GP is over Zoom or over a computer. But then when the doctor orders lab tests, let's say blood tests or other kind of pathology and all of these things, we have somebody goes to the home or the workplace or wherever the patient happens to be, and collects a sample, runs a test, shares the report with the doctor. The doctor then does a follow-up consult to provide the diagnosis. And we've gone further also when there's prescription of medicine, that the doctor is able to order it to be delivered also to the home. Of course, you're aware Aetna is also part of CVS, the wider pharmacy network. So we have all of that. The broader delivery of healthcare across all of the different, let's say, channels happens through that first point of call, or the entry point is telehealth, and then the rest of it happens. And to the patient, this is convenient. It cuts their time down to 20 minutes instead of a 3-hour round trip to do all of this, at least. It's also safety to the patient because they're not having to sit in a busy doctor's waiting room. They're not having to stand in a pharmacy queue. They're not having to interact with others at the time of social distancing. So our patients really started to love it. And the quick turnaround times. We're able to, from consultation to labs being collected within the hour sometimes, to medication being dispensed within another hour where required. So within that kind of time frame, we're able to do that. And then when there is a referral to a specialist, that happens through a tight network or a very specific network of physicians that we work with, specialists across all fields, where our GPs are able to refer into them. Our team can book the patient into them, can call them and remind them of their appointment, all of these practical things. We've even considered, we've run a pilot in the US where we even book them their Uber just to make sure the patient goes where they have to physically go. And all of that kind of thing, to be able to get them to their specialist consult, get them back and get the consultation notes or the medical record updated back to the GP, so the GP is able to follow up later and keep that overall 360 view of the patient's health.
That's wonderful. And a couple of kind of points I got out of Osama, you brought up a good point, is we're starting to move away from and even in the public systems, but we're moving away from like fee-for-service or just episodic care, more towards value-based sort of longitudinal care, right, of responsibility of patients, which we all know we need to. And Joe, of course, is as a payer and insurer, and the other thing that we're seeing, which is quite big. So that model gives us more flexibility on how we want to care for our patients. So it's not just about the clinician seeing the patient. It could be like Penny talked about multidisciplinary team meetings, which is clinicians, but it's in a different way where we're looking at the best plan, care coordination, wellness and prevention. How do we educate? And that, Joe, I'm sure, as we talk about risk assessment and management of some of your chronic population is, when we do risk assessments and we look at chronic disease folks who might end up in the emergency room, it becomes a quality of life and a health issue, but it also becomes a cost issue, of course, as well. And how do we use this technology appropriately when appropriate and focus on specific populations when needed? It was interesting though, when in the middle of COVID, Forrester actually did a really interesting report, and this is, and I apologize again, but this is a U.S. focused report, but close to about 50% of all of the virtual visits in the U.S. during the heat of COVID, when it was extremely high percentage of, was just for general practitioner. It was just GP, and we had a great question from Mohammed on our panelist group there about different models, and we'll talk about that without getting as much information, but about 50% was just general elements every day. Hey, things that we would have needed to go to the doctor for. My ankle hurts. I feel like I got a cold, this. Penny, you're probably not surprised about this, but as a neuropsychologist and, mental health, about 30, I think it was 30, and don't get me exact on these numbers, but about 36 to 38% was actually mental health, was the use of virtual care. And then the remaining, which is a very small number, was actually related direct to COVID, where patients actually had COVID and it was used. So it just shows the power of the technology across that spectrum. And we just think it was just COVID patients being seen. No, a lot of it was just to keep the wheels moving of healthcare for things that we needed to actually do. So, okay, we have about 15 minutes left. Now, I think this is just one of the most important questions and discussion points we're going to have today, because we're all on this call. We've all been through, everyone, like I say, this acceleration where countries were literally just pushed into using digital technology. Like we didn't have a choice, basically, in a lot of situations, right? And it just went like this. But now that we've been through this test, now that we know that it's a viable model, now that we know that virtual technologies, regardless if it's video, remote patient monitoring, store and forward, whatever that might be, can be effective. I'm going to ask each of you, and we'll have to keep this kind of short because we're running out of time here, and I want to be able to get the questions from the actual audience. But the question is, we don't have a crystal ball. None of us do. But what's your vision of what the future of healthcare can look like and what it might look like? And if any of you don't have to answer the second part, but I've heard people say, in the future, kind of like, I don't know I don't know what it's like around the world, but I know I haven't been to my bank in a long time. We just do everything virtually. I don't even know what my bank looks like hardly anymore. Everything's through. Do you see maybe in healthcare someday, it'll be a digital first approach to healthcare where people will interact with the medical system digitally first? So what do you see the future of virtual care? And then if you want to answer that second question, not as important, but, Safaa, let's go ahead and start with you, please.
Yeah, sure. I'm actually very excited about this question, and I believe it's a very important one. You don't have to ask me whether I see it's a future thing. It's already happening. As I said earlier, probably most of the elements been discussing the importance of having that virtual intervention through primary care practice and psychology, probably and psychiatrist, psychological aspects, and so on and so forth. This is very important and very crucial and very helpful, but I've also seen it in other, care delivery, like telestroke, tele-ICU. We're talking about ECMO. We're talking about hospital at home. We're talking about home care. Like, we've already activated so many of those inpatient services that we've seen a really good outcome coming out of it. So I would like just to reflect on a true story. Here. I'll try to be short and sweet. I know we're running out of time, but it's really a cool one. There was actually an old man who was exposed to symptoms of severe headache, numbness in the face, and difficulty in movement. The patient was actually transferred to the nearest hospital in his area, and he arrived at the emergency department. The doctor on duty suspected that the patient was suffering from stroke symptoms, as all emergency doctors associated with our virtual medical center are actually trained in stroke symptoms due to the importance of quickly discovering these cases to maintain the health of patients through the speed of response. So meanwhile, the doctor in the emergency department of Al-Baha Hospital in this scenario immediately contacted the stroke consultant at the virtual medical center in Riyadh, and the consultant requested a CT scan after conducting an initial medical examination using modern technology. A stroke was discovered, and the consultant in the virtual medical center gave the medical order quickly to intervene, and giving the patient the liquefied needle is like, and that was amazingly happened. And I'm not even exaggerating. I was there watching this case by myself, like from door to needle, it took only 16 minutes. Well, actually, believe it or not, as per guidelines, it should be like, ideally speaking, 1 hour, and you shouldn't probably exceed 4 hours or 4 hours and a half giving that thrombolytic therapeutic needle or injection to the patient to actually save him from a significant losses. But if we can respond to something like that in a quick manner using digital health, using technology, can you imagine how many patients we can actually save, how many actually families we can save from suffering? You know that knowing that the guideline actually just justified 1 minute, and you can do it using certain technology in 16 and 25 minutes, and this is really amazing. So of course, fortunately, this patient's life was saved, and he left the hospital within a few hours without any significant losses. And you can imagine how this technology was able to preserve the health and life of patient and fill the need in the rare specialty, and how this technology actually covered problems that are not limited to patients' health only, but preserve also the unity and cohesion of families and preserve their social life and roles. Basically, as you know, 15 million people probably worldwide suffer from stroke annually, so 5 million of whom die. So if we can use digital health to save cases like that, and we've seen it, the distribution of specialty care. We don't have enough neurologists. We don't have stroke specialty doctors distributed across the country, and people are dying because of that. Because sometimes providers, even if they have doctors, they still, as I said earlier, part of our job is not only to deliver care through digital health, but also training providers in remote areas through digital health. Like these doctors are actually trained. We activated stroke codes in these areas. We trained providers in these areas to actually provide, know how to detect those symptoms, how to contact the specialist right away using technology. It's just insane. It's just insane. And I just wanted to share this story because it really touched my heart, and I felt proud watching how could the stroke team here, saved many cases like that using digital health.
That's a wonderful story, and I'm glad you got to personally experience that, especially when we work kind of in sometimes at different levels where we don't get to see the day-to-day how what we're doing impacts patients, right? And it's interesting the point you bring up, and I'll go on, but stroke, of course, it doesn't happen, of course, thank goodness, a lot, but when it does, it provides high specialty treatment. And what Safaa's referring to, a lot of clinicians understand this, but there's an ischemic stroke, which is where you have a blockage, and there's a hemorrhagic stroke where you have a bleed. If you have the blockage type, there's only a window, and it depends on where you're at, but I know in the US it's 3 hours, where you actually have to run thrombolytics to break that clot. And to Safaa's point, if you can get in there, but 80% of strokes, I know this is from Australia and I've done in the US, are basically, and then probably around the world, but are basically ischemic strokes that can receive the treatment that you talked about, Safaa, but because a lot of people can't meet that 3-hour window and get that expertise that you talked about, a vascular neurologist or a stroke doctor, the percentage of people that actually receive TPA is quite small. So this is just a great example of the power of this technology. That's really exciting. You got to see that and actually be there. I don't usually get to see them walk out 2 or 3 hours later. I actually have a bachelor's degree in nursing, and I did a little bit of per diem in the OR and experienced some of the same things, but that's a great story. So no, thanks for sharing. That's great. So we do have a question, and Osama, I'm gonna take a little different angle on this question with you, like the future. We actually have a question from a physician on the line who's asking specific questions about, licensure, about practice and license. So, but when we did our preparation call, of course, we're all sort of restrained. There's reimbursement. How do we get compensated for what we're doing? Or if you're in a public system, does a virtual visit count as an actual interaction? And then the other piece are regulatory and policy issues, right? Of course, state, licensure issues, restrictions, do you have to be licensed in the country? I don't know if you can see the question there, Osama, but do you mind sort of like the future taking on both of those during this question? Is that okay? I know I'm kind of switching gears on you.
So actually,
Okay.
what I can say that this is the changes required to support virtual care and telehealth is already happening. Speaking about the UAE, we've already launched a modification to the medical responsibility law that allows virtual visits, and even consider them equal to face-to-face in terms of its legal implications, like you can have a prescription, you can make a diagnosis for certain diseases. And we took another further step, like DHA. Now we are developing certain clinical guidelines for the usage of virtual care in certain specialties and certain disease management. So this is another good step to make things safe for doctors to use virtual care without going into malpractice issues or legal issues. Also at DHA, we implemented a full program to license telehealth platforms and digital health platforms. And we look at them, we inspect them from the privacy point of view, from the security point of view, from the interoperability point of view. Now it's a must for you as a hospital, if you want to integrate a telehealth solution, this solution should be seamlessly integrated to your medical records. This is very important to make sure that the virtual care is part of your digital pathways. This is a very important point. We also now we add requirements with regard to save the or restore the virtual care sessions for 30 days for quality purposes, and also if there's a complaint coming from a patient. So now we are having some sort of a complete regulatory and compliance framework around virtual. This is very important.
Wonderful. I think, one of the questions is, and I'll kind of give an overview. We have a question about about country licensure, I guess. Is there any code of regulation like in Saudi Arabia or UAE for rehabilitation service providers around the world to deliver their services, right? And I can tell you the way it generally works. And this is a very global. I'm not gonna ask Safaa and Osama or Joe specifically, but most countries, of course, mandate that the provider meets the certifications within their country or has a medical license within their country. So I think that's the first thing that anyone, if you're a provider and want to provide services to a different country, that you have to meet that. That's the first thing. Every country is different, though. Of course, some countries will say that, most countries I work with, they don't care they don't care where the provider's at. It's basically what's called the originating site. It's where the patient is physically located during the time of the actual encounter. If that clinician is licensed in that place, because I think if you think about it, and maybe it's different, but let's say the patient's in Safaa in Saudi Arabia. If the patient's 100 kilometers away from the doctor, they're 100 kilometers away doing things virtually. Now, if they're 5,000 kilometers away, it's just a longer cord, but they're still doing the exact same thing, right? But the question is are there any regulatory issues that the physician has to be within the borders of that country? And every country is different. So Safaa, do you want to just add a little light on that, please?
Yeah. Actually, you touched a very important example, and we should hear, for example, it came across my mind now as you're speaking, when the service is synchronous or asynchronous, when it requires a critical intervention, or it's, like maybe radiology or maybe any other shape of care delivery, where the doctor, it's okay for him to wait a little bit more until he gets back to the patient and so on and so forth. So in this scenario, for example, if it's critical care, we also focus on 4 elements before giving the green light to go and activate the service. Some of them are technical requirements, like, for example, what is the minimum technical requirements that we really have to make sure that we have in place, like, for example, the level of connection availability, the type of technology, how sensitive the camera should be. If it requires, the doctor has to have, a live, access to certain organs or whatever, because it's an urgent care. All this stuff has to be documented and agreed upon and make sure that are in place. And we have to have, for example, business continuity plan in case if the system is down, or, all these aspects, because you really need to make sure that the care is actually delivered safely. So you need to ensure effectiveness and safeguard patients and doctors. But of course, you cannot activate the service and reach out to excellence from day one. But we have what we call day one requirements or minimum requirements to activate the service. One aspect is the technical, as I mentioned. The second is the legal. We have medical legal requirements. For example, you mentioned probably credentialing, privileging of the doctor, because indeed the practitioner practicing physical or the traditional way of practicing medicine is different from virtual. So they have to be credentialed and privileged differently, working within different scope of service. And this has to be identified and documented. And also when it comes to safety requirements, you really need to make sure that the care is safe. Not because we're very excited about technology, that means we have to go under-regulated, because this is really scary. I always say we have to be regulated with a light touch, because that balance is very important. But of course, make sure always when it comes to regulation, make sure that you work for efficiency and safety first. And that's it. So yes, we do have regulations when it comes to activate virtual care, and yet we're still evolving in that area, and we're building more and more regulations and guidelines in that context.
Wonderful. Thank you very much. Now we're down to about 30 seconds for each answer, and I apologize, Dr. Trainer, hate to do that to you, but just one, and then Joe, just one, what do you think the future looks like?
I know mine is sort of a circumscribed area of healthcare, but certainly the future for neuropsychology is a hybrid model. We've run surveys, and clinicians, 90% of clinicians intend to carry on using hybrid video conferencing for clinical interviews, but only 50% intend to carry on using it for testing purposes. So I think what we're going to see is exactly as I outlined at the start, that we will identify where it fits best and be using this entirely blended hybrid model. Exactly the point that Osama made. It's not a bolt-on, it's not something separate. It needs to be entirely integrated into the service plan and the care delivery plan. And I think that's what we're going to see. So it's exciting times. I'm glad to be part of it. So yeah, thank you everyone for today.
Thank you, Dr. Trainer. Joe? You're muted, sir.
I think what we'll see, and I hope that's what we'll see, is of course hybrid, sure, all the way. Also digital first, all the way, across specialty areas, and to really fix the structure of healthcare, being primary care being the entry point, and then navigating through to specialist care. And what digital is going to offer us in all of these points is a lot of what Safaa was saying: the efficiency, the speed of responsiveness, speed of access, the more readily access, and all of these things. But they shouldn't become shortcuts to the system, or spaghetti of the system, or even snakes and ladders board game of the system. The system, I hope, would maintain its structure with primary, secondary, and tertiary care, but that digital would allow these efficiency improvements, access improvements, and speed of response.
All right, and we are 2 minutes over, so we need to go. Well, first of all, I just want to thank the attendees, and I want to thank you for the very thoughtful questions and input. And I wish we had more time to answer them, and because I think we could all go on for a long time. But thank you very much for attending, and I really want to thank our distinguished panel. Dr. Penny Trainer, thank you as always. Dr. Osama ElHassan, thank you. Safaa, thank you so much. Joe, thank you very much. And a big thank you to ISfTeH for the great work that you're doing and that you continue to do. And Zoom looks forward to working with all of you in the future. So have a great day, night, morning, wherever you're at in the world. And thank you so much for the great conversation. Have a good day.